I'd now like to introduce the Aboriginal Health Panel. It's my pleasure to bring back Nicky Turner as the facilitator for this session. And as mentioned before, Nicky is a proud Gamilaroi woman who currently lives on the New South Wales South Coast. I'll introduce the panel, starting with Valerie Smith. Valerie is a proud Wiradjuri woman from Dubbo, Western New South Wales. She's married with 2 beautiful children, and Valerie lived in Dubbo all her life and moved to Port Macquarie going on 4 years now. Valerie has been an Aboriginal health worker since 2015. She worked at Dubbo AMS as an Aboriginal health worker for 2 years, and in this time completed her Cert 3 and Cert 4 in Aboriginal primary health at TAFE New South Wales in Dubbo. At Werin, where she works currently as a care coordinator and Aboriginal health worker in the Aboriginal and the integrated team. And since joining Werin, Valerie has completed her Aboriginal primary health practitioner studies with TAFE New South Wales. Welcome, Valerie. I'd now like to introduce Emma as a Gamilaroi woman born in Moree but grew up travelling Australia with her parents who are ministers. Before becoming an Aboriginal health practitioner, she worked at the Condobolin Public School with kindergarten. Emma was given the opportunity to work at the Condobolin Aboriginal Health Service in February 2014. Emma went on to complete her Cert 4 in Aboriginal and Torres Strait Islander primary health care in 2016 and is now a registered Aboriginal health practitioner. Emma loves her job because it gives her the opportunity to work in the community and help her people while trying to bridge the gap between health service and community. I'd now like to introduce Laurie. Laurie Clay is from country, and Laurie is the proud father of 4 children and grandfather of 3 boys. He has worked in Aboriginal community controlled services on the mid-North Coast for nearly 30 years. Currently, Laurie works at Werin Aboriginal Medical Clinic and has been there for 5 years. As the Aboriginal Health Workforce Team Leader, Laurie mentors and supports all Aboriginal health workers and oversees the coordination of all of the chronic disease clinics. Laurie also provides extensive support to the clinical team on a daily basis. Welcome, Laurie. Finally, I'd like to introduce Sean Kinchela. Sean is a Gamilaroi man from the northwest of New South Wales and currently living on Newen country on the far south coast of New South Wales, working in Katungul's Aboriginal Medical and Community Service as the Ear and Eye Health Coordinator. Sean started at Katungul as a trainee back in 2017 under the guidance of a former manager, Dean Haycox, who taught Sean everything he had learned for over his 15 years of experience in ear and eye health. Sean completed his traineeship in 2018, also completing his Cert 4 in audiometry, furthering his skills in bone conduction and masking techniques to utilise when needed during children and adult ear health screening. Outside of working in Katungul, Sean is also a graphic designer, a photographer, a videographer, clothing brand owner and a hip-hop artist, on which he tries to use those platforms for education and guidance for our communities. Welcome, Sean, and welcome to the panel.
Hi everyone, welcome to 2020 RDN Outreach Forum, and it's great to have an expert panel here today. You've got the best of the best of health workers that work around New South Wales here with us today. So this is something you just couldn't pay for. There wouldn't be enough money in the world to have these wonderful group of people here on this panel. And just thinking about the Outreach Forum and the theme for this year's Outreach Forum, Resilience in Healthcare, and how perfect is this theme considering what we've all been through over the last few months. So I'd just like to thank Laurie, Sean, Valerie and Emma for spending your time with us today. So we've got a few questions for the panel, and I'm sure they'll add in things that they sort of know from over the many years that they've been health workers within the sector. But the first question is, why did you become an Aboriginal health worker? So I open this up to all of you, and you can sort of fight over who would like to go first, but I will pick someone to go first, and probably Emma. I think that'd be great if you start off with why did you become an Aboriginal health worker?
Wasn't even in my employment, like I didn't really want to be an Aboriginal health worker, but I got asked to come on board the Condo AMS. I was in the schools before this year and I didn't even consider health, but since coming about 6 years ago, I just love it. Just seeing the need that the community needs, needing someone that's Aboriginal that's going to go out, that's going to care for them. And, yeah, I love it now. Yeah, so I love working with my people, with my community, yeah.
Yep. Thanks, Emma. That's really important. Seeing the need and working with community is what we need, especially in our communities, and seeing people from our own communities working with their own people. So thanks for that, Emma. Sean, I'll go over to you. Same question. Why did you become an Aboriginal health worker?
Yeah, I was pretty much the same. I never thought I'd ever have a career in health. I started as a traineeship, and once I started going out to the schools and actually seeing what the community needs were and how important it was to have someone that was Aboriginal and deliver an appropriate service to the kids, to the communities. So it really grew on me too, become real passionate and started looking further into what career paths I can go with it.
Mm-hmm. Yeah, great, Sean. That's really interesting also, and starting as the traineeship and working your way up. And I know we're going to hear more about what you've done in the next few questions, but also that appropriateness and that passion. So that's really important also. So thanks for that. Valerie, why did you become a health worker?
I became a Aboriginal health worker because I wanted to empower my people to take control of their health and just be aware of things out there and stuff, and I just want to to close that gap and close it much more quicker.
Yeah, wonderful. A couple of things you said there about empower and aware, really, really strong words, and that's what you're doing in your community, which is so important, and encourage our people to take control of their health and close that gap. So thanks for that. Laurie, you've been a health worker for a very long time. And
yes.
A few years since you're a young man. What made you go in to be a health worker?
My journey was, like everyone else's, quite unique. I started out in the building trade, and basically we had 3 young children. I figured, I need to know a little bit about first aid. So I trained as an enrolled nurse at the Kempsey Hospital. And after that, I did some relief work at Durry AMS in Kempsey. And I like the community model of nursing. I figure the regimentation when people get onto the wards was quite foreign. That early intervention, that secondary health, I figure there was a far better and more enjoyable way of health for healthing. So the community I was working in, I didn't come from, but it was really enjoyable how doors open, how you met people, the diversity of what people were actually doing, but also giving people the survival skills and the opportunity of breaking down some of the jargon so people could actually understand what we're saying from the scientific point of view in the community language that people could actually understand. And, health promotion was a big part of that as well.
Yeah, thanks, Laurie. And I know your journey, and I hope people get in contact with you and find out about your journey coming from the building trade into being a great role model and a wonderful health worker that you've done for many years. And like you said...
Did you say play model?
A role model. And did I say play model or role model?
No.
And doing what you've been doing for many years, and working at Durry for many years and helping a lot of people, especially in the chronic disease program, and then going on to Werin. But your story is wonderful. So we'll move on to another question, and this is for everyone too. And what is the most challenging and rewarding part of your role? So we'll go to, you sort of said a bit of it, but we might go, we'll start off with Valerie. What is your most challenging and rewarding part of your role that you do today?
The rewarding part for me is seeing the clients take some empowerment of their health. So they're starting to know a little bit of jargon, what's going on. And if they don't, they ask us, or we don't know, we'll go to Laurie. And the challenges would be,
sustainability.
Yeah, sustainability of it.
Yeah. I thought you might have said that Laurie might have been one of the challenges, Valerie, but that's all right. You're the way you look at it, man.
Always, Nicky.
No, but that's great, and it is about, and it is very rewarding when you're talking to your clients, patients, community, and you know their understanding. So it means that how rewarding that is, that you know that you're teaching someone else something and how to look after themselves. Emma, I'll go on to you. Same question. Challenges, rewarding. You can talk about both. You can just talk about one if you like.
Challenges is just when they go in with the doctor, just getting them to understand what the doctor's saying. Like, that's a really big thing for us, like, because we have doctors that are not Australian, so their language and how they speak. But rewarding is that they're asking for us more. So they're asking, okay, I know I need this help, so can you come in with me while I talk to the doctor? Can you tell me what this means? Can you tell me how I go about doing this? And so it's rewarding that they are being more acceptable, asking more questions, wanting to know more about their health, wanting us to go in and be a part of their health journey and getting better. And Yeah, great. Thanks, Emma, for that. Now, I think it's really, really important, especially when you said about that health literacy. And this is where, I think I always talk about this, that the Aboriginal health worker is critical, absolutely essential to the care of our Aboriginal clients and essential to the position at Aboriginal Medical Service. Without having our Aboriginal health workers, there's a lot of things that wouldn't happen. So that health literacy that you spoke about is really important. Sean, I'll go to you. Same question. Challenges, rewarding. I know you talked about a bit about going from your traineeship and where you are now, that you've done so much to get there. So some of the challenges on the way and how rewarding it is to be where you are now.
I think challenges is just not having enough Aboriginal health workers on the ground and getting more to actually come in and understand the importance of coming in for the health checks. The rewarding part, me working with the eye clinic and that, is just being able to give people their free spectacles and allowing them to see, like they can go and read forms and understand them. And just same thing, like coming in and actually asking for help and understanding medical terminology in a way that we can interpret it.
Yeah, really important. A couple of things, yes, especially about the health checks. This is a very a big part of Aboriginal and Torres Strait Islander of our care for our people. And you said about the eye clinics, and for you helping people to get glasses to be able to see, to read forms, changes lives. So that's really important. Yeah, so that's wonderful. Laurie, I'll jump back to you about, in your long career, about a lot of the changes you've probably seen, but a lot of challenges and the rewards that you've seen also.
Yeah, Nicky, it's, they've got to understand that they're Aboriginal medical services, not Aboriginal management services or places for student places. They're Aboriginal medical services set up to address the inadequacies of Aboriginal health. But we keep getting, throwing stats and KPIs and, these models of health. And, even for the simple fact is, the BMI really doesn't correlate and relate to a lot of what our mob does. So the challenge is that the science of the pathology and what goes on, but knowing community, knowing even the staff that are patients as well, their comorbidities, they're building into things like continuity and survival, that empowerment. The challenge is basically who replaces person A when they go to retire. How do they take away and reinvent all that experience and knowledge that people have, getting an Aboriginal workforce that's young, that's sustainable. Actually, when people say going to conferences and what have you, having that relief funding to bring people on when they go on long service leave. The simple fact, a lot of our workers don't live long enough to get their superannuation. We should be looking at ways to challenge the government to actually, if we're dying at 17 or 20 years younger than mainstream, it should be going back into any Aboriginal sustainability for the workforce. So, there's things have been giving people the freedom of choices, giving them all the information, whether they're looking at their blood glucose levels or spirometry, but also for Aboriginal medical centres too. And something I found over the years is don't devalue the bush medicine that we use and how people can actually go back to country and a range of the things they can actually use in treatment management. So cohabilitate with synthetic medicines, and as much is we might use acupuncture and a range of things outside synthetic medicine, but I value the bush medicine that's actually used within all communities.
Yeah, thanks, Laurie. That's really good and wonderful. A couple of things you said there, and also traditional healers, like you said, bush medicine. There's traditional healers, and I know a lot of them are being used around the country. And I think more and more of that getting back in our communities would be really wonderful too. And the KPIs is really important. We have to make sure our community and our people come first. Yes, there has to be structure, but our community has to come first, and the rest have to follow. So that's really, really important. So just another question, I suppose, for you, Laurie. What are the unique skill set and values that Aboriginal and Torres Strait Islander health staff and health professionals bring to the services?
It's a good question. I mean, you have to be pretty thick-skinned to start with. You also have to be aware that, people might be talking loud and aggressive towards you, but a simple fact, they might have a hearing impairment or an impediment, so to speak. So it may not be their mannerisms, which some people might take as antisocial and behavioural issues, but a simple fact, it could be that the person couldn't be hearing. So not being judgmental, not having those tagisms can be, it's quite unique to the AMSs, but also the cross-cultural safety and training, not only for our staff, but our patients, especially when we have student placements and locums come into the workforce. And especially when our patients go to hospital, they're not to be treated as statistics and numbers to be pushed out the door in that regard. So it's a matter of being able to portray that communication. Our reputations in the AMSs are really important, because we've got to be doing it better than the rest to be considered even equal when you talk about the partnerships with the funding guidelines, and our services are equated on statistics and presentations. So there's a lot of things that we need to do to build ourselves up as a economic base as far as knowledge, skill sets. The knowledge and skill sets that the AMSs have, particularly the Aboriginal health workers, are as basic as defined as staff that work in A&Es and ICUs. It's quite unique. It's a specialised field working in AMSs, for the simple fact, a lot of what you'll see here, people might only read in textbooks. They may never see a measles outbreak or whooping cough per se. So we should be actually acknowledged for the work we do. And the Aboriginal health worker just isn't, as I used to use all the jargon of silos and body parts. We're holistic. Generally, patients will come to a person as their first point of contact, whether you work in the Mums and Bubs program or you're working in chronic disease. They build up a rapport, and therefore you're their conduit, for a better word, to all other programs being referred and or follow up. So you've got to be very multi-skilled, very multi-dimensional in how you actually deal with things. Once again, your terminology and your jargon, anywhere from a blood glucose level equated to a blood sugar level. So there's a lot of things to be valued, and I suppose there's a lot of things we do until we sort of sit back and have a look. We don't realise how much we actually do. I was saying to Val earlier, that's 24/7. You just don't clock off. If someone asks you a question in the Isles of Woolies on a Sunday afternoon, you've got to be able to respond. But also looking at and valuing the skill sets that our patients expect from us. It's not always stuff that can be done with a certificate on the wall.
Yeah, thanks, Laurie, and that's so true, and that's something that people coming in to work at a medical centre need to be aware of. And the other thing is that you said a lot about it there also, is this cultural knowledge. And, as you all know, I've worked in Aboriginal medical service before and worked as a health worker, and, the Aboriginal health worker at the Aboriginal medical service or wherever they're working has got this cultural knowledge, community knowledge. They know what's going on around. So that's another reason why they're so vital. So I'll open this up a bit too. I'll go to you first, Valerie. What are some of the tips that you can give other people who are interested in working in Aboriginal health or the Aboriginal medical service? So this can be Aboriginal and Torres Strait Islander people or non-Aboriginal and Torres Strait Islander people. So what are some of the tips that you could give people that who are interested in working at an AMS or in Aboriginal health?
The biggest thing is listening and patience and trust. If they don't have your trust the first time they meet you, well, that's going to be hard to get. I believe that's I think that's the way I was brought up, with respect and listening and making them feel welcome, making them feel important, that they are important when they walk in the door. And you look at the holistic approach of it, not just their sore toe that they're coming in for. So it's their background, it's their journey, and I think listening is the biggest one that you can have.
Mm. Yeah,
because they don't want to come in and repeat their story over and over again. I know I don't, but yeah, I think that's the big thing.
Mm. Yeah, great answer. That listening is really, really important, and that trust that I think that we don't give people enough of, especially when you said around appointments and different things. You know, we're all in such a rush to get people in, get people out. It's that sitting down, asking, finding out the story. Yeah. Emma, over to you too, Emma, about that. Have you got some tips for people coming in wanting to work in Aboriginal health or in Aboriginal medical service?
I think they need to have a passion for it. You have to have a love for your community to do this job. It's hands-on, it's full-on. And if you come in just for the dollar, it's not going to work. So they need to have heart for their community. And, yeah, I just think there's a lot of people that just come in and just say, well, this is easy money. But you have to love your community and love your people enough to work and do the hard yards. Sometimes it's not just a 9-to-5 job. It's after 5 o'clock when we all go home. You get the knocks on the door at 3 o'clock in the morning because there's something wrong. So you have to be dedicated and committed to your community and to your people. So, yeah.
Yeah, great, Emma, thank you. And it's that commitment, isn't it? That's really, really important. Yeah. Sean, have you got any tips from what the other ladies have said?
I completely agree with trust. Like, instead of listening to act, just listening to people, just so they have someone to listen to. Because a lot of our mob don't have someone to talk to that they can actually just yarn to without having a reaction or looking to act on it. And same with the holistic care, like being an Aboriginal health worker. Sometimes we're not just doing OBS, we're out in the community, we're yarning about mental health, housing situations, financial problems, housing pathways, and what else? Same with trust. Like, I know with our medical service, we don't get many full-time GPs, so a lot of our clients do have to re-explain their situations to new GPs all the time, and they don't want to do that. So I think just continuity with the clients in the community, communication and commitment and passion.
Yeah, thanks, John. And really interesting there, communication, passion, this communication that we have to make sure it's both ways, and listening and trust. So, yeah, great. Thanks for that. Okay, we'll go on to another question. This can be everyone also. What can employers do to make a difference to Aboriginal health workforce career development and advancement? What do you think is the main thing that employers can do? I'll go to you, Laurie, first.
All right. Look, probably a couple of things. People get promised the world and they do their traineeships and scholarships, and then they're cut through. There's not always a career pathway for people to follow up, and you can understand why people would not want to take those opportunities up. But so long as whoever's employing people, they deliver on their promises, that they basically don't put themselves in a situation where they take away the values of that individual as well. So that might be their ideals, their sexuality, and a range of things. It's basically valuing the people for who they are. Also letting them know that if you work in the AMSs, you're never going to make $1 million out of it. But as Emma said, I don't think any of us that are working in health have that sort of facade that we think that we're going to come out the other end a lot more financially compensated. So I think even if the government when they look at the wages of the Aboriginal health workers compared to the Aboriginal staff in mainstream public health, there's a gap there even between the health workers if you look at that. So some sustainability in that. I think when they're doing these training programs, such as you've got a panel here together today, they should be looking to engage the expertise of the Aboriginal health workers. So when they're doing the Aboriginal health worker and Torres Strait Islander practitioner courses, they should start to look to get some real value from those that have been working frontline or have that experience, not just, some of the TAFE teachers or the registered nurses they might be, not that they're saying that they don't know what they're doing, but certainly when you're looking at what we've got, what we're compounded with day in, day out, as you say, confidentiality is a big thing, making sure that people understand that, especially when we're explaining things with health assessment and GP management plans. It's important, but giving that handover to the doctors, so the doctors having the trust in the health workers to be able to say, all right, look, I understand what you've said here, because the written word for us isn't always the way things are explained. So being able to verbalise a lot of what we've got is very, very important in that regard. I think medical literature in that regard's a big thing, but also, our sorry times, the different times in the community that we've got to be away to pay our respects. I honestly believe if, after this COVID, if showing nothing else, people can be away and can be handicapped by what goes on. So having released staff and or wages, or having the staff being able to negotiate that in a way that they're not financially disadvantaged because of their culture, that should be, respected, and there's got to be different ways that can actually evoke, better outcomes. I don't know how many RDN specialists there are that are Aboriginal. We've got some fantastic staff that visit our service, and we couldn't be happier with them, but just the equality in that, if that was the case. So looking for, employment opportunities outside the scope of what we've got. And even for the Aboriginal health workers, when we go online for continual professional development, there's not a lot of courses you can actually do to keep up your hours, to get up your 20 study points for the year. And what we actually do facilitate at the front line, we've created things here, some clinics that aren't funded, but just through the simple fact of referrals and what have you. So I think you've got to be a little bit flamboyant with what you do, but I think there's a lot of accountability for those masters that give us the crumbs off their tables.
Yeah, thanks, Laurie. And as the Aboriginal Workforce Engagement Manager for RDN, I'll take that on, and we can talk about some of those things later about what you mentioned. We're going to have a time at the end to talk about a couple of those also. Has anyone else got anything to add to that, or otherwise we'll just move on about career development? I think Laurie mentioned a lot of things there. Sean or Emma or Valerie, did you have anything else to add to that?
No.
Okay.
Nicky, can I just go back to something you said at the start? There were a specialised panel, and you're with RDN. Are we getting specialist pay rates for this? Is that part of this today?
I will take that on too, Laurie. Okay, that's part of my role. I'll take that on. I'll jot that down. Okay, and I'll take it.
I mean, you're using expertise and knowledge. I think we'd like to be, how can I say, compensated for our values and our knowledge. Yes.
RDN drink bottle, okay?
Oh,
in
wow.
In the mail.
Just don't send me one of them orange shirts, whatever you do.
Thank you, Laurie. We'll move on, and this is a question that is really interesting, and a lot of people, are very interested in this question. There'll be a lot of people online that are interested in this question. And what makes an Aboriginal medical service different from a GP practice or community health centre? So, Sean, I might go to you first with this. There's lots, we could talk about this all day because how important AMSs are, but from your point of view, what do you think, why are AMSs so important and different to a mainstream service?
I think mainstream service is just 9 to 5. AMSs, all our workers are 24/7 workers. We always got mob over home asking questions. People inbox on Facebook all hours of the night. We're family orientated. GP services is just 9 to 5.
Yeah, thanks, Sean. That's really important, and as health workers, as someone else has already said, you're always on call. It's a very, you're always there for the community. And I think, Emma, you said that before about the passion. You have to really have it in your heart. So I'll go to you, Emma, next. And the same question, just what's the difference between AMSs? How are they different to mainstream GP services or health clinics?
I think we are different in the fact that we focus on a holistic care. We focus on family, home, everything to do with that one client. We look at their whole health, and that doesn't just mean them as an individual. It means where they live, how they live, Also, we offer a lot of transport here. So if they need to go to specialists, they don't have to take their own car. They don't have to drive. We'll drive them, even to the appointment with our doctors. They can just call up. We'll pick them up. We offer incentives. So in order to get them in to get health checks, we give them an incentive. And we're culturally appropriate for our Aboriginal people. That's the main important thing that Aboriginal Health Services offer, is that we're culturally appropriate. Yeah.
Yeah, great. Thank you, Em. And I think people online, if they want to know more about how health services started, to look that up, because all those things that you and Sean have just mentioned are in there. Why did Aboriginal Medical Services first come about? And exactly. And Valerie, I'll go to you. Is there anything else you wanted to add, also from what Emma and Sean just mentioned about?
No, just like what Emma was saying, the holistic approach about the whole thing, where if they're going into a mainstream, they're going there for that sore toe. Where they'll come to an AMS, a lot of our elders will sit down, have a cuppa and sit down and relax, and before they go in and talk to a doctor. So, yeah, I think that's and it's family, they feel comfortable there.
I think that's the mind, body, spirit of that holistic things we talk about. It's not just the sore toe. And Sean, you mentioned before, and Emma mentioned housing, education, all those things that we think about is why is it so important. Laurie, have you got anything else to add to that, being in AMSs for a long time?
I think that one of the big things about the AMSs is making sure that our doors stay open, that people access us. We're a alternative form to mainstream health, but we still have to adhere to the same APRA registrations, AGPAL registrations, and a name of things. We're culturally more appropriate for Aboriginal people, but not all Aboriginal people use our service. But in saying that, it gives people that alternative, a choice where in the past they wouldn't have. Some of the Aboriginal medical services started as health outposts that were funded by mainstream. So, even the interpretation of language that people use and being able to understand how they're trying to communicate that. The simple fact that, there's drug and alcohol issues, certainly up around this way. We have the Kempsey jail, so how important it is for people to transition back into the community, and then also those Australian citizenship things they give up by going to jail, then they've actually got to relocate and basically re-access once they come back into the community. And some of those individuals don't have any other opportunity bar the AMS. If the AMSs aren't here. The AMSs are important. The simple fact, a number of staff that work here are related to most of the community. And what you were saying before, and Emma and Sean, I agree with that basically we know the community and the things they're doing. So if we've got an urgent recall or referral for a person, knowing where the card game is or the bingo is, when that's been facilitated, what we do at our sports and what have you, it's like a social corroboree of people coming together. So the times of day, the places that people are actually going to be at. So knowing the community is most important in that regard. It's accessing and knowing with the pharmacist that person might be owed a script. They ring us up. We can get the script to them without the patient presenting, so to speak, but can also have that script facilitated and filled. So there's a range of different things that we actually do, and there's probably more if we sat down and had a look at what we do that would value a lot from our own points of view what we do. So, but we wear many different hats, and then you look at the career paths a lot of our staff have taken, and where they've come from to what they're doing now. They basically they coordinate specialist clinics, which in itself, for some people, can take years to do. And here we are, people coordinating, hearing clinics, eye clinics, neuro clinics, ped clinics. I mean, you've got Aboriginal health workers that some staff take 10 or 12 years in mainstream to be able to, and here they are expected to do it. Aboriginal health has always been about, let's fix it and pay for it later, so to speak. But there's a time you've got to start paying us for what we're worth and the value that we have. We're not just tokenistic that mainstream uses our numbers for statistics to validate their existence. We're basically validating their existence, not our own in that sense. So all those things you talk about, closing the gap, your KPIs, the holistic health, are all great words, but there's things that we do that's so valued on the ground, you basically really can't quantify. And the simple fact is, I suppose, is we exist because of the community. We exist because of the ill health and Aboriginal health in the community. We're here to basically address those issues.
Yeah, thanks, Laurie. And something interesting that you said there, and, we talk about prevention a lot, but the other thing is, without you, just imagine how many of our people would be a lot sicker in hospital. This is the other thing that we have to think about. How many people do you, in your daily roles, prevent going to hospital of our Aboriginal and Torres Strait people? And that would be a lot of people. Talking about specialists, I'll go to you, Emma, and if you could just talk about the work you've done with the optometrist and the retinal cameras and different things that you've done in your role. If you could just chat about that and how that's changed. And you're a specialist in yourself, and so is everyone else. But just to talk about your role with the optometrist.
Okay, so I've just taken over the role of the Optum Phoenix, probably the last 3-4 months. So I'm fairly new at it, but we've got a retinal camera, which is fantastic. We had a patient that has come from another service, came down, had a GPMP done, and needed her eyes checked because they've changed her medication. So we took a photo of that eye. We found that there was some bleeding happening behind the eye, and we've sent all that off, and we've gotten her in to see an ophthalmologist. So I'm really enjoying working with the eyes at the moment. They come every fortnight. I also do the hearing. So I organise all of LAS's, like Australian Hearings appointments. I organise all of Brian Holden's appointments. So I've got that. I'm the only Aboriginal health practitioner here at the moment, so I'm on my own. So it's a really big load, but I'm loving it, loving the challenge, loving working with the community,
That's really good, Emma, and congratulations on what you've done there. And again, just think about if you weren't there, what would be happening. Yeah. Our people wouldn't be getting like you said, with the client with the bleed behind the eyes. What would happen? We don't want to think what would happen. More than likely not be able to see today and the hearing you're doing. So congratulations, good on you. Sean, I'll just jump to you because I know you're doing the eye clinic also. So maybe a couple of things that you've picked up and the role you do also.
I think the diabetic retinopathy camera is like one of the best things we've ever had. Like, it's so good being able to take a photo and show the client so they can understand, rather than hearing from an optom and not understanding it. They can actually see the damage that's happening behind the eyes and the importance of managing their diabetes and of like smoking and all the other factors. And I've been doing eye clinic for about 3 years now. It's the best thing. The diabetic camera is like just the best.
Yeah, it's good.
Yeah, that's wonderful, Sean. And again, explaining to people what things mean. We like to be visual. We say our people are very visual, and explaining that. And then you can say, give prevention also, and talk about things that, which Laurie, you've done for many years, but talk about prevention and what's the cause for this to happen, and what people can stop doing or do more of to prevent this happening. I'll just jump on to the next question about collaborations and relationships. Valerie, I might go on to you. Just how How important do you think collaborations with other mainstream organisations and AMSs are? Or Laurie, I'm happy to anyone.
No, we're just having a quiet moment. Val also coordinates our eye clinic here, so it's great to see that there's 3 people here that are very passionate about the eyes. Well done.
Sorry, Val, I didn't know. I'll go to you about that then. I didn't know you did that. So now we've got 3 eye people, which I'm very, very happy to have on here. So something from you, maybe. Just how do you see? You got a camera there also?
Yes, we've got a camera. I also dilate the client's eyes if they're diabetic. So they're 45 minutes in with fast. And it's good to explain to the patients that the first drops are going to sting, the second drop's not going to sting that much, but they're going to open up the pupils, and the doctor's going to look in the camera behind your eye. So just like what Emma was saying and Sean was saying, that they can pick up a lot of things from that. So yeah, it was good. Yeah, I love it. It's good.
Yeah. No,
and I've got a clinic coming next month, 2-day clinic, so I'm excited to get back on board with that.
Yeah, no, it's great to make sure we've got our people coming back in for our clinics, because that has worried me also that we haven't had people coming into clinics. So thanks for that. So I'll go back to the question just about looking at collaborations and relationships. How important are they for Aboriginal health and for the organisations?
Yeah, it's very, very important to have that relationship, not just with the clients, but with the whole organisations, with the doctors, the visiting allied health workers, nurses, down to the receptionists, everyone. It's yeah. If you don't have that,
and you might, yeah.
And one of the big things there too, I suppose, Nicky, and you can testify to this, it's a lot of the times it's the personalities in those positions that either get the work done or don't. And, you build up those networks, which is important, but the wider scheme of things, those positions exist, but it's not always the same, let's say, personality or egos in those positions. And if you haven't got that rapport or that network, things basically become quite stagnant. If we're looking at anything from discharge planning or inviting people to the table as a community reference group, if they're not getting the right sort of balance with what goes on, the people aren't sort of just advocating for one mob rather than, say, the whole valley or the whole nation, so to speak, it can be quite interesting how things will actually turn. So basically having that rapport, and this is where, your relationships, your friendships and that build into it, but professional respect. You might be an Aboriginal health worker, but that shouldn't diminish if you're an ENT specialist or a nursing unit manager at the hospital. We're all paid health professionals, we're all humans. We're all here to do the job. It's all about nursing and healthcare and health professionalism, allied health specialists. Everybody's done their time either tertiary or in the trenches, so to speak. And that shouldn't be diminished because you can't pronounce or don't know the big words, because we all try and get people, to the table as far as either procedures go or empowering so they can basically stay out of hospital, stay away from those specialists if we're giving them those survival skills. So it's really about the networks of respecting your colleagues, depending and not depending on what uniforms they do or don't wear.
Yeah, thanks, Laurie and Valerie. And I think that the 3 of you working in eye health, you would do a lot of relationship building collaborations, like you mentioned, with the Brian Holden Vision and everything else you do with the optometrists. So you might look and think, I mightn't do much, but the relationships you form and the trust you form is a lot to have the optometrist believe in you, feel comfortable with you and trust you in doing all the work you're doing. So well done to that also. And I think, like you said, Laurie, relationships are really important, that we have to make sure we all work together. So I've got a couple of more questions. I suppose, how has the natural disasters, the fires, but as recently COVID, changed the way you practice, especially around telehealth, and how has that affected your practice where you are, and also the community?
We haven't really changed much. We didn't close our doors. We were still seeing people all the time. Doctor did offer, there was telehealth offered to our patients if they didn't want to come in. For specialists, we offered telehealth or Zoom so they could come in and get on the computer and do a video link with the specialist, save them going to Orange and Dubbo and places like that. But our doors were kept open. We didn't close at all.
Yeah, great. Thanks, Emma. Sean?
Yeah, we were pretty much the same. We stayed open. We really just encouraged practicing social distancing and that. If you're sick, make sure you ring before you come in so it didn't endanger other clients getting sick. But really, we're just the same. Everyone was still encouraged to come in and get their health checks, flu shots.
Yeah, thanks. And I know, Sean, you had the bushfires down there also. That you've had double whammy also down that way with the bushfires, and I know that you went through a lot with the bushfires also. So how did the bushfires affect you? You still had your services going also?
Yeah, we still had our services going. A lot of our community teams were out delivering food packages and needs, and just trying to help mend our community back after all the disasters. And it's only just starting to get back to normal now, even after 6 months of the bushfires have been out.
Yeah. Valerie and Laurie, the same question about services and telehealth, and how did it work there at Werin?
Well, Nicky, I suppose, as I say, with the fires, we were affected. We were sort of closed there for a day and a half at various stages. Staff couldn't get in because of the smoke in and around Port Macquarie and up to Kempsey, so she was pretty intense in that regard. Then you had the covert. So during the covert early stages, we had about 5 staff that were, for a better word, stood down, laid off because, one, they were Aboriginal, and 2, because they're chronic conditions. So we lost 5 staff at the start of that. So when you consider the amount of staff that we have and that we're understaffed, it certainly put a huge expectation on the rest of us. And there was things like we started to do the screenings outside in the marquees. So people, the questions that were being asked, if they met certain markers, they could or couldn't go, and then the quarantine rooms. So we had to actually have 2 quarantine rooms, which we still don't have any purpose-built or enough rooms as it is. So that changed the whole service that we do. Things like our infection control and contaminated waste. We went from 1 Zulu bin a month to 1 a week. So you could see the amount of work that we're actually doing that. We were Zooming internally daily to keep up to date with the current trends and also our social distancing. And basically went from mopping every day, make sure that the place was mopped, clean and sterile in that regard. So there was a big financial cost, but also a social and emotional well-being cost. Staff were, having to stay at home to look after kids that had coughs and not getting the results back quick enough. So where a cough might have cost them a day's work, was costing some people 3 unpaid days' work because of that. So I suppose politically, if you look at it, the money that they were giving to people that weren't working, considering the people who were on the front line and how they were disadvantaged or what they were doing either through registrations and fuel and what have you, there's certainly a different way they could have actually gone about and rewarded the people that chose to stay at work to help their communities, help the what had out, rather than try and disadvantage them. But anyway, that's another political statement for another time. But it certainly has an impact on us with our skill sets, what needed to be done, and people were a lot more heightened awareness, where we had our communal bicky jars and lolly jars and cricket and things like that had to go by. So even the culture, what we were used to doing as an organisation, a lot of that changed in that regard. But it certainly had a big impact. And the smokers didn't like it the most because they couldn't stand around smoking for too long. So at the social distance.
Oh, that's a big issue. But the lolly jar and the bicky jar, Laurie, I know you always had those, so that would be a very big issue there. But and you probably would have heard nationally, and a lot of webinars and presentations I've heard over the last 4 weeks at least saying AMSs have done a marvellous job in making sure the cases are very low to nil in our communities. Most of the cases for Aboriginal and Torres Strait Islander people have come from Aboriginal Torres Strait Islander people that have come from overseas. There's been very, very little community cases known. So again, congratulations to you as health workers, because it's a known fact and it's been talked about a lot at a national level that Aboriginal health workers and Aboriginal AMSs have made sure this has happened in community. We're not over yet, but the work you've done and the AMSs have done has been tremendous in communities. And the other thing you mentioned there, Laurie, is out-of-pocket expenses for the organisations. You know, no one seen this coming, so a lot of your PPE and things like that now that you said about the disposal bins, things like that have been used that no one knew, that this was going to happen. So that was a big issue.
And it's once in a lifetime event that a lot of us haven't lived through. But yeah, we do live through bushfires and droughts and floods. So we're pretty residual and we do survive. And I think, fortunately, if this COVID had got into some of the Aboriginal communities, would have absolutely wiped them out. There's no denying that. So either that social distancing, we got onto it enough, or the messages that were put out there with the literature and how we actually supported that probably goes a long way to, once again, you're looking at our model of health.
Mm-hmm. I think that's the part, the model of health, Laurie, and that's sort of what's been talked about in the model of health, and AMS has got onto it a lot sooner than other practices and just said, this is what we're going to do, and we're going to make sure our community is protected in this. I've just got one last question before I open it up to anything else you want to talk about, and what role, if any, can RDN play in supporting inter-organisational or coordination in your region or other regions across the state? So is there a role that you think RDN can play in helping your organisation in coordination?
More training, education, maybe?
Yep, around what Laurie mentioned before. Laurie, something around that? Yep. More training for health workers, training in your CPD points, things like that?
Yep. Yeah.
Yeah, Nick, and it doesn't have to be face-to-face, even if it's online modules, so to speak, everywhere from hand washing to, those masteries, so to speak, things like using spirometries or doing HbA1cs and ACRs. I know Quams does that, but using those as examples, so to speak. You got your hearing, certainly your eyes. We've got the advocates here to, how passionate they speak about the knowledge that they've picked up and what they're actually doing. So you can't really pay for that passion, but if you've got frontline workers, even if we use the eye program as a standard model, you can see how that's going to empower other people. And without the obvious, I think in each AMS you probably need 2 or 3 people in every position to be at least have the knowledge to either facilitate that clinic or take up a run, because we deal with a lot of sorry business. Who relieves the staff when they're away on annual leave or sick leave in that regard? So we really need to build sustainable models so that on-the-job training, one, is important because every AMS is different how they run about and get things done. But I also believe that if we get someone who can champion us, like say RDN for that instant, why not be the good corporate citizen and get on board and support things that are already working? You're going to get the pat on the back for the work we're already doing. There's our collaboration, our networks and what have you. And the idea then is who do we pass this on to, so the next generation all coming on, so to speak. So it has to be very personable in that regard as our service delivery. And those that are facilitating it too, it's not about certificates on the wall, it's using a dialogue and a language that we can digest, that we can empower those people back in the community.
Yeah, great. Thanks, Laurie. Valerie, have you got anything else to say for what Laurie just said? I'm going on from that.
No, I think Laurie summed it all up.
Maybe what were you going to say before you want to say?
Sean, anything about how RDN can help coordinate more?
No, I just agree. More training, online training, especially for AHPs and AHWs.
Yeah.
Yep. Great. Emma?
No, I think, that's it.
Yep. So I'll open up to you now. I've finished sort of doing the formal questions. Is there anything else you wanted to talk about before we finish? Anything you want to put out there? before we finish? Anything burning topics that you would like to talk about around this outreach forum? So I have a few hundred people listening to you talk about your expertise. And I learned a lot today, and I know health workers, like I said, are critical to the Aboriginal medical service and has to be valued, one of the most valued people in the service that does so much work with your community. So we might.
I suppose,
Laurie?
Nicky, you've got the likes of NACCHO and AHMRC that here in New South Wales, but nationally as well, people can tap things into. But it's basically knowing when people might go to land councils or sports or whatever. And as I said, the AMSs aren't the answer for everything, but we certainly are. We take away a lot of the curl out of the question mark, for a better word, with Aboriginal health. Not all Aboriginal people come from those areas too, so knowing and understanding their mobs, and when they go to hospital, the simple fact that the culture and their body language doesn't always represent how they're feeling, how they want to communicate in that regard, and that when they do those blocks, or they do those residentials at those local hospitals or even the AMSs, that listen with your ears and not with your mouths, because there's a lot that can actually be learned. And, it's a confidence thing too. We don't always want to be shot down for the values that we have, either as a culture and a nation, or even our work practices, so to speak. So just be understanding that we do things and they work because they work. We don't always actually have to deconstruct it to find the good of what we do.
Yeah, thanks, Laurie. And that's really important, talking about people, placements, qualifications. It doesn't matter who you are, but if you're coming into an Aboriginal medical service or coming into Aboriginal health, you need to make sure you listen and look at body language and ask questions to experts like yourselves. So if there's nothing else that anyone else wanted to talk about,
just my bank details for the payment, Nick. I'll give you my ABN and all that a bit later on.
I've already got them. I told you, drink bottles coming your way. Drink bottles.
Oh, yeah.
So thank you everyone for your time. It's been wonderful, and I'm sure that the audience online will get so much out of what you've talked about. I'm sure they'll probably be in contact with you to talk more with you. So thank you very much. Take care and keep up the great work.
Good to catch up with you, Nick. See you, Sean. See you, Emma.
Bye. Bye.
Bye-bye.
Thanks, Nicky, and to the panel for that session. Well, that concludes the scheduled forum. I hope everyone has enjoyed the forum in this digital format. I'd like to thank all colleagues on the excellent presentations given, and I'd also like to particularly thank all of you on a Saturday coming together to experience and share in this new digital format. I wanted to remind everyone that there are 5 additional excellent presentations available on the digital venue at Rural Health Pro that can be streamed at any time, and there is something for everyone, including an administration refresher update on reporting, pain management, hearing health, rural town specialist models of care in the Hunter New England, and a presentation on recognising the impact of childhood trauma and knowing how to respond. I'd also encourage all of you to use the Rural Health Pro digital venue to continue group conversations and connect as a network, a unique network, on topics that you have sparked your interest during the webinar, and just more generally to stay connected with colleagues. We really value your feedback as well, particularly as we grow in our ability to deliver forums in any format, including this one. And we would really appreciate if you could complete the feedback form located on the digital venue. Also, importantly, check back into Rural Health Pro digital venue on Monday for the announcement of prize winners. Finally, on behalf of the team at New South Wales Rural Doctors Network, RDN, I'd like to say thank you for attending and wish you all well. Bye for now.